The below-the-knee amputation is one of the oldest procedures in medicine, so today it represents one of the greatest challenges in diabetic limb preservation. The irony is that the BK often considered a successful outcome when compared to an above knee amputation because we're preserving the knee, but it's still a devastating event that often represents years of disease progression. So the question is, how did we get from a small pressure point underneath the foot to losing the leg below the knee? Welcome back to Diabetic Clip Files. I'm Dr. G. So, an amputation is not just the removal of a body part. Is the end result of a biological, mechanical, vascular, and sometimes preventable pathway. Patient doesn't just wake up one morning needing a below the knee amputation. The journey often begins years earlier with diabetes, neuropathy, vascular disease, changes in the biomechanics, pressure, skin breakdown, infection, and eventually tissue failure. But why is the below the knee amputation the most common major lower extremity amputation? Why is preserving the knee considered one of the greatest victories in limb salvage? And how can we as podiatrists become the front line defense against patients ever reaching to that point? So the history of the lower extremity amputation. So of course, amputations existed for thousands of years. Early amputations were often performed because of traumatic injuries from war, infection, gangrene, accidents. And historically, the problem was survival. Can we remove the dead tissue? Can we stop the infection? Can the patient survive the operation? And modern amputation philosophy has changed because of anesthesia, antiseptic techniques, antibiotics, vascular surgery, prosthetic advancements, and rehabilitation science. So today, the question is no, forgive me, no longer where can we remove the limb, whether or not, but the question is what is the lowest level that will heal while maximizing the patient's function? So, who invented the modern below the knee amputation? So, there's not a single inventor of the below the knee amputation. It actually evolved over centuries. However, there's several surgeons who helped shape the modern amputation surgery. So, Ambrose Parry, often considered the father of modern surgery. Perry, P-A-R-E with the apostrophe on top of the E, revolutionized amputation techniques in the 1500s. So he introduced improved surgical techniques, better hemostasis, improved understanding of wound management, and more humane approaches to amputation. Before this period, amputations were often crude and performed rapidly. Yeah, I remember it was before, not that I personally remember, but before they had anesthesia, a successful amputation was how fast they were able to do it because the patient didn't have anything to numb the pain. So also James Syme. So known for the Syme amputation, SYME, at the ankle, which influenced the evolution of the distal limb preservation. Now also Ernest Burgess, one of the most influential figures of the modern below the knee amputation. He developed principles that are still foundational today, such as preserving the knee whenever possible, selecting functional amputation level, creating a durable residual limb, considering prosthetic rehabilitation. So the modern BK philosophy became preserve the length, preserve the knee, preserve the function. So why did the knee become the most valuable joint? So the knee is biomechanical masterpiece. It allows shock absorption, energy conservation, controlled movement, sitting, standing, walking efficiency. And a person with the below the knee amputation still has their femur, their knee joint, their quadriceps, their ability to control limb positioning, and above the knee amputee loses the knee mechanism that requires for a prosthetic knee, and they will require a prosthetic knee, which requires significantly more energy and training because the knee is not just a joint; it actually is a mode of independence. So, why do patients need a below the knee amputation? The major indications are peripheral arterial disease, PAD. So, that's one of the most common reasons the artery becomes narrow or blocked, the foot becomes oxygen starved, and this leads to ischemia, tissue necrosis, gangrene, and non healing wounds. Next is diabetes related foot disease. So, diabetes creates the perfect storm. As we know, with neuropathy, the patient loses their protective sensation. They cannot feel. pressure, trauma, heat, or even repetitive injury. Vascular disease, which causes the reduced blood flow that limits our healing, as well as immune dysfunction that happens, and the infection can progress much more easily. Now, when it comes to infection, the pathway for us that we commonly see is small ulcer that develops into a deep infection that causes an abscess, which can cause osteomyelitis, as well as a sepsis risk, as well as the amputation decision as it continues to progress without any intervention. So another reason for BK is trauma. We see this with crush injuries, motor vehicle accidents, and industrial injuries. And then another major indication for BKs are malignancies. Rare, but tumors involving the bone or soft tissue may require amputation. So, why does diabetes create a perfect storm for a BKA? So, diabetic limb loss usually follows a predictable pathway. So, step one would be hyperglycemia. Because of these chronic elevated glucose levels, it damages the nerves, it damages the blood vessels, it damages the immune function. Step two would be neuropathy. So, the loss of protective sensation means that the foot can be injured without the brain receiving that warning signal. So a person can step on a foreign object, a sharp surface, or even have a poorly fitting shoe and continue walking on it. Another stage is biomechanical abnormalities. So as we know, diabetic neuropathy changes the foot. So there's intrinsic muscle wasting, digital contractures, prominent metatarsal heads, altered pressure distribution. The foot becomes a machine producing excessive stress. And then, biomechanical breakdown. So this is like, your foot is not just skin and bones. It's a mechanical system designed to redistribute forces. So during walking, there are pressure shifts, joints move, muscle stabilizes, the plantar surface absorbs the repetitive stress. But with neuropathy, your intrinsic muscles are weakened, the toes can become clawed, deformities can develop and pressure points increase. And the foot begins creating its own injury. So a callus is not just thick skin. Calluses are a biological or biomechanical warning sign telling us, hey, something is repeatedly causing repetitive stress and excessive repetitive stress here. And underneath that callus could be hemorrhage, tissue breakdown, and ulceration. That's why it's so important not to self treat your callus. You have to go to the doctor to make sure that there is not a diabetic ulcer underneath there or skin breakdown. Okay, you should catch a callus early. And as we know, the excessive callus can hide a subungual. I say subungual, forgive me, subdural hemorrhaging, tissue breakdown, and an ulcer. And then we have to think about infection and bone involvement. Osteomyelitis develops. That is a point when limb-salvage does become more complex. Nobody wants to hear that they got diagnosed with osteomyelitis. It is a big deal because the only way to get fully rid of the infected bone is to remove that part of the infected bone. Okay. And then we have to always, that's why we love vascular so much when it comes to vascular failure. They help us with that because when the body cannot deliver enough oxygen to heal, the question becomes, can this limb survive? So, we know that our foot needs oxygen. The wound becomes metabolically demanding. So, healing requires oxygen, nutrients, immune cells, and collagen production. And peripheral arterial disease reduces the ability to deliver these resources. So, combine that with neuropathy, pressure. Now we have a classic diabetic foot catastrophe. So why do we want to save the knee? Like why they fight to save it, okay? It is one of the most important joints in the human movement, okay? It's a modified hinge joint designed for stability, mobility, shock absorption, and energy conservation. So in the knee, the bones are the femur, the tibia, the patella, and then the ligaments are the ACL, PCL, MCL, and LCL, and they control forward movement, backward movement, rotation, and stabilization. The menisci, there's the lateral and the medial meniscus, and that helps distribute load, absorb shock, and protect the cartilage. Then we have our quadriceps, which are very critical for standing, climbing stairs, and controlling the prosthesis, okay? And then our hamstrings, which are very important for knee control and gait stability. So, why were we preserving the knee? Because the knee allows the patient to have lower energy walking, it improves the prosthetic control, it's easier transfer, and greater independence. So when a patient gets above the knee amputation, so the AKA, patient loses the biological knee, they must rely on the prosthetic knee mechanism. So, what are the mortality and outcomes of a BKA versus a AKA? So, major lower extremity amputation carries significant mortality risk because it is a usual marker of advanced systemic disease. So, studies consistently show high mortality after major amputation, increased risk of diabetes, PAD, kidney disease, and cardiovascular. So, approximate survival patterns are reported in literature. So below the knee amputation, aka a BKA, right? I say aka BK. I'm saying BK, below the knee amputation. 1 year mortality, often around 20 to 40%, depending on the patient, the population, and 5 year mortality can be approached by about 50 to 70%, unfortunately. And with above the knee amputation, it's generally worse outcomes because there are higher energy demands. There's reduced mobility and it has more medical complexity. So, some studies have shown that 1 year mortality rate when a patient has a above the knee amputation can often be 30 to 50% or even higher. A 5 year mortality rate can exceed 70% in higher risk groups. Okay. The difference is not just only the surgery, but the amputation is a sign that the patient has a severe underlying disease. So, how often do diabetic patients end up with below the knee amputation? So, not every person with diabetes develops an ulcer, and not every ulcer leads to amputation. However, diabetes is associated with the majority of non traumatic lower extremity amputations in many countries. People with diabetes have dramatically higher risk of lower extremity amputations compared to people without diabetes. A significant proportion of major amputations in diabetic patients are below the knee amputations because preserving the knees preserving the knee improves the function and rehabilitation potential of the patient. And in many patients with diabetes as well as PAD populations, below the knee amputation represents approximately half or more of major lower extremity amputations. So the exact percentage varies by country, healthcare system, access to vascular care, limb salvage programs, and timing of the referral. But the biomechanics after a BK, so, the BK actually changes the entire gait cycle. The patient loses their ankle joint. They don't have an ankle joint anymore. So the ankle provides propulsion, balance, and shock absorption. And the calf muscles create push off power, and a prosthesis must replace that and have energy return, stability, and foot progression. But the remaining limb also becomes quite critical because after one amputation, the patient is now at increased risk for contralateral ulcers, pressure redistribution problems, and further amputation. And, the patient loses part of their lever arm of their foot, their ankle power regeneration, and their natural proprioception. So the body has to learn to adapt. And the compensation may include altered hip motion, changes in walking speed, increased energy demands, increased pressure on the remaining limb, and this creates another important decision. The first amputation is often not the end of the story. That usually is the truth. And the remaining limb becomes quite vulnerable because the patient may shift their weight, most likely will, biomechanics change, and the opposite foot experience increased stress. So the question is, how can podiatrists help change the story? Okay, we can intervene through prevention, annual diabetic foot examinations, neuropathy screening, vascular assessment, biomechanical correction addresses the abnormal pressure, the deformities, the footwear, the offloading, because pressure is the enemy we can measure and modify. Early wound intervention before infection spreads, debridement, cultures when appropriate, advanced wound therapies, offloading, and multidisciplinary care. And then, and most important, limb salvage teams. So the future of collaborations, podiatry, vascular, infectious disease, endocrinology, prosthetics, wound care specialists, everybody. Okay. And in final closing, you know, below the knee amputation represents one of medicine's greatest paradoxes. Paradox. It's devastating event, but preserving the knee may also mean preserving the patient's independence, okay? However, the greatest advancement in limb salvage is not about performing a better amputation. It's about recognizing the pathway early enough that the patient never reaches that mm, treatment intervention, okay? That's why prevention is better than cure, right? And the future of diabetic foot care is not about just simply saving limbs, it's about saving lives. We already talked about that. And this has been Diabetic Foot Files. I'm kind of on a stretch for time today, but this has been Dr. G, and take care of your feet because they take care of you.